Good evening, everyone. Thanks for having me. Thanks to LCI, and thank you so much for sharing your story. I've got some slides for some of the research that I've been focusing on, and I'll hope to make them digestible for you all. These are some of the relevant disclosures for funding that I've gotten. I wanted to start off with it kind of in two sections. This is a patient who presented to me to clinic for a nodule found on her X-ray. It's in the bottom left here. Oh, we have no. Let me see if I can put on a pointer, pin and pointer. Yeah, does that work over here? This little hazy area here. This is in the middle of the lung, back on the table, chest up top. It's like you're the lady in the magic show. I say you're getting cut across side to side, and this was found on an X-ray for cough. This patient had a PET scan, and PET scans are activity scans. In this area, it doesn't have much activity at all. If there was activity, you'd see bright yellow or at least some red. Basically, no activity at all. We watched this area for about 4 months, and it had essentially no change. 10 months later, this patient presented to the emergency room for shortness of breath, feeling unwell, coughing, got antibiotics and steroids, had no improvement, and then over another month with worsening symptoms, finally got a CAT scan of their chest. And these gray areas in the middle of the chest are areas where lymph nodes live. Lymph nodes are an area that cancer often spreads to. This was evaluated with an activity scan, a PET scan, and you can see these bright yellow areas in the middle. And this is this fluid compartment, like a Ziploc bag of fluid next to the lung that's now newly present. And this patient ended up having a bronchoscopy and was diagnosed with small cell lung cancer. Lung cancer being kind of two big buckets, small cell and non-small cell. So these are the two, we kind of lump these into localized to the chest, limited on the left, an extensive stage spread outside of the lung on the right. We treat non-small cell lung cancer slightly different. And this is a trial published back in 2014 showing how quickly patients are no longer with us with this disease, depending on whether they got no therapy at all in red, or more and more chemotherapy in the two blue lines. And you can see this is a pretty aggressive disease. When it hasn't left the chest, average survival is probably 6 months to a year. When it's left the chest, survival is probably more like 6 months. And it kind of depends on whether you can get or tolerate treatment for it. This has had a big change in the last 40 years. Just finally, in the last 5 years, we've got new medications. No change for 40 years, and now finally, new medications and new hope. That was the dismal part. I'm supposed to be bringing in hope, and so I will try to do so. This is just trial results. The point to know is that the yellow line means that more people are alive than the people who were in the blue line, and the people in the yellow line got immunotherapy. Okay, this is in people who it hasn't left the chest. They got chemotherapy, radiation, and immunotherapy, and it doesn't seem like a dramatic result. The median or middle time, 33 months versus 56 months, but again, the first improvements seen in 4 decades. This immunotherapy is an important new drug, and I won't spend a lot of time here, but the immune system in blue is constantly attacking cancer cells, hopefully. And one way that cancer cells escape is by putting out a little stop sign, this PD-L1 purple stop sign saying, no, don't worry about me. I'm just normal lung tissue, for instance. And so this infusion in green is a little antibody that blocks that stop sign and allows the immune system to kill cancer. And this is overly simplified, but gets to the point. And this similar effect is seen in patients with cancer that's left their chest with small cell, so extensive stage, metastatic stage small cell lung cancer. The blue line better than the red line, and this blue line really extending for many years. It's a small proportion of patients that are still alive at 5 years, but still some patients are, where in the past it was far less. And then there's new medications. This is a second line therapy. It's not quite immune therapy, but it does interact with the immune system, so I guess you could call it that. But drugs like tarlatamab, this is after you've progressed on the previous therapies, um, improve survival on the next line. And there's even more first line therapies approved in just the recent times, with more complicated names that we need to get into. But part of my focus is on lung doctors, pulmonologists. What do they know? So the first approval for immunotherapy in small cell in the first line setting, I think, was in 2019. And this survey was last year. And we asked people, how familiar are you with immunotherapy in this cancer? And you can see about half. This is split up into limited being blue and red being extensive stage. About half of pulmonologists really don't know this therapy exists. So it's the first advance in 40 years, and most lung doctors, often a first contact for patients with lung cancer, don't even know that the developments have occurred. We asked, why might patients not get referred for treatment? They universally reported and by the way, this is an unpublished survey. It's hopefully submitted in the next few weeks, but this is not peer-reviewed data as of yet. Most people who were, almost all patients were referred by about 400 pulmonologists answering the survey. But we asked, well, what if they didn't accept the referral? What was the reason? And it was this most common reason was patient refused referral. They didn't want to be treated for some reason. A few other highlights: maybe patient didn't have the family support or transportation or otherwise, and then a small percentage, maybe 20%, that you were concerned the patient was too elderly or had too many other medical problems that would limit treatment. And then we asked a couple questions about pulmonologists. We asked several, but these are two highlights. We asked them, how often or how much do you agree with the treatment for this cancer being worse than the disease itself? And in blue, about 63% either didn't agree or disagree, or agreed that maybe the treatment for small cell is worse than the disease. And in the second question, we asked, would you agree or disagree with it? It's mostly up to luck if a patient with small cell lung cancer survives more than a year or two. And about 40% agreed or was neutral on that question. Up to luck, just luck. And so it gets back to the phone call that you mentioned. When these patients receive these phone calls from a pulmonologist about a new diagnosis, small cell is a very aggressive cancer, and for the last 40 years, pulmonologists and other doctors have seen time and again very poor survival. But with new treatment advances, we have to make sure that our pulmonary colleagues, primary care doctors, and others know about these advances, so that if someone is maybe thinking about not taking that referral, that at least they're armed with the knowledge of the current treatments to make sure that they consider. That's something I certainly always do for my oncology colleagues, is you don't have to get therapy, but please see an oncologist. Miriam Alexander, John Rangel, Chris Rangel, my colleagues in oncology, make that decision with them, not with me. So this patient, 2 years after presentation, receiving chemotherapy and immunotherapy, you can see that hazy spot down here is still the same as 2 years ago, hasn't changed a bit. And those spots that were in the middle of the chest, these kind of intermediate gray spots, are gone. She did have one new spot in the brain pop up. This was the first time outside of the chest, and it was treated with a single dose of radiation, and at this time has no evidence of disease. So for small cell, with some of these results that I'm getting to learn and to review, we have the first advances in very recent times in the first 40 years. These advances are not biomarker driven, like we'll talk about in the second part of this talk, and that patients and clinicians have to know that some of these options are there to help guide appropriate referral and combat nihilism and to have hope. The second section, I want to talk about some of the recent research and findings I've had regarding non-small cell lung cancer. So non-small cell adenocarcinoma, squamous cell, those are all synonyms. This is a survival curve. So how many people are alive across the x-axis years here. And you can see this is for stage 4. So this is metastatic or stage 4 lung cancer. This is older data from 1990 to 2000. And you can see many patients are dead before the first year, unfortunately, is out, and very few are surviving 5 years. As your stage is less, the less spread you have, the longer people tend to live. This is an old study from the 2000s where people were comparing chemotherapy plus supportive care in blue to just supportive care alone in a yellow. And you can see that dotted line is median survival, probability of survival at 50%, half people in this trial alive. And the difference at that median point is only about 3 months. So at that time, chemotherapy maybe gave you a few extra months and maybe arguably gave you some quality of life and maybe also hurt that quality of life depending on your reaction. This is the next patient's images. They presented with progressive respiratory symptoms. This is their main lung mass that's highlighted on this activity scan. These other spots are lymph nodes, and then these small dots are presumed cancer spread areas, too small to light up on this activity scan. This patient underwent a bronchoscopy, and biomarker testing was ordered very quickly, both on the tissue. We have to do this extra sequencing and testing of the tissue and on the bloodstream. Both tests returned with a mutation in the EGFR gene exon 19. This patient, just to get to the chase, was treated with an EGFR tyrosine kinase inhibitor, and this shows this original area here shrinking and scarring down with no evidence of anything growing at this time, remains on therapy and living their life. This is the trial that shows that this new generation EGFR tyrosine kinase inhibitor was better than its comparator, so the blue better than the red. But if you overlay the earlier clinical trial, it's not a fair thing. It's not like we're really comparing the two, but this was the old trial for chemotherapy. So really the difference is in EGFR therapy, a targeted type therapy compared to chemotherapy, the outlook is far superior. And in this trial, patients' median survival was over 3 years rather than just maybe 6 months. And for pulmonologists, many of the pulmonary fellows I gave a similar talk to didn't know what this reference was, but for lung doctors, many people are asking how many needle pokes does it take to get biomarker testing, and it's a question that I'm very interested in. But yeah, all the kids these days in training, medical training, have no clue what that reference was. On the left is a survey that we published in 2021 asking pulmonologists how many needle sticks they do of a lymph node or a lung mass. And most said 3 to 4, but there was a 30% little group here who did far more than 3 to 4, trying to get more and more tissue. On the right, this is not my data, but it's a review of multiple studies, how many passes. And so you can see as you approach 6 passes, you approach 90 or so percent of getting the answer. But it's way more complicated than that, and I'm going to try to convince my pulmonary colleagues that that's not the right way to think about it, in that at every step of the way, from biopsy to testing, makes a difference. This is a depiction kind of a lymph node. Sometimes you got a lot of cells. Sometimes it's completely replaced by cancer cells. If you stick the one with less cancer cells, you're going to have to stick it a lot more to get an answer. You'll see pulmonologists, if you're watching their new procedures, they'll hold the little specimen come up to the light looking for little things floating in their sample to see if there's enough. But you don't know if those little spots are little specks of blood clot, if they're chunks of tissue, chunks of cancer. You just don't get to know. There's a lot of things that you can put these cells in, these different solutions, and some of them actually affect your ability to do biomarker testing. Our pathologists love when we create slides, little bits of tissue on a slide smeared across, because they can be very valuable. These are one of my patient slides. These little purple marks, I should have exploded these a little bit bigger here, are areas, groups of cancer cells. You can see this one has more, this one only has one. And then what happens to that cup? That cup gets spun down to a little tiny pellet, put in wax, cut open and put on a slide, and you just don't know what's in that cup. Sometimes you get so little that they try to cut it and they can't really cut it and you get nothing. And sometimes it's plenty of tissue for any and all testing that needs to be done. And then what do you send it for? This is too much. I know it's too much. I haven't had time to fix it. But there's a bunch of different tests you can run. They need different amounts of tissue, different amounts of cancer cells, and they all don't work the same. And so in the end, you've got a pathologist who's looking at a sample who might say, I don't think this is enough. But you always have to know, does that pathologist know what you're sending it for or not? Because if you're sending it to a commercial laboratory that requires big chunks of tissues, you may not be able to get biomarker testing completed. But if you're sending it for a smaller focus panel, something that we have available at MUSC, where our pathologist will even scrape a cellular slide to perform this testing, then maybe it is adequate. And so we'll often call our molecular pathologist and say, hey, this said there wasn't enough, but would you review the sample for us? And they'll say, yeah, you maybe not get every little thing you want, or maybe there's a chance you get it all. Let's try. And so there's this final step of someone has to adjudicate, is there enough or not? And sometimes they may not know. Finally, there should be a sense of urgency. I like that you had that to be a piece of your message. This was in a collaboration. This is also unpublished data, accepted but unpublished. A collaboration with one of the commercial testing companies, looking at time from biopsy to completion of results being available from 2018 to 2024, 62,000 lung cancer samples, the average time going from 36 days to 27 days. There's a lot of variability. This needs to be a little bit bigger, but we took the fastest 40, or the first quintile, so the fastest 40 and the slowest 40, and they were pretty different. A difference of 20 days on average versus 40 days on average to get your test results. And then keep in mind how quickly some patients are expiring with stage 4 cancer and how urgent this is needed before their first treatment. This is time from biopsy to order, about 14 days. These big red bars mean there's a ton of variability across the sites, and no improvement from 2018 to 2024. This was our shipping and handling time. Once you order it, how long does it take it to get to the company? About 4 to 5 days. Find it, package it up, send it to the company, have them receive it. And then the only improvement, the driver of the improvement, was how fast the company could run the sample. They went from about 13 days or 2 weeks down to about 1 week. So once they got it, they ran with it as quickly as possible. And the unfortunate thing is this time to order. And this is an area of my intense focus because most people who have a new diagnosis of lung cancer haven't met an oncologist yet. They have to be referred to one. And so pulmonologists very commonly diagnose lung cancer, pathologists see all the samples. How do we coordinate the ordering of biomarker testing to the point before the medical oncologist, but in collaboration with them? That is an area of my intense focus, and basically the grant I have from the American Cancer Society to look at that issue. So I only covered the one metastatic lung cancer case, but these therapies are gaining indications across most stages of lung cancer now. So this testing is really relevant for almost all new diagnoses. Communication with the medical oncologist, pathologist, pulmonologist about we need the tissue, how do we handle the tissue, where is the tissue going, where do we send this sample for the testing, and of course, time is critical and this information is urgent. Have to thank my primary mentor, Dr. Gerard Silvestri, and the American Cancer Society, and thanks again for LCI inviting me. Everyone in the back there, my clinical colleagues in the back, thank you for your help over the years. That's all.